Thank you so much for that. It's a great way to move into really thinking about how justice, as you name it, affects our mental health field and the things that we can do. So thank you so much for that. And we're going to hold those concepts in our minds as we talk to these. I just briefly want to talk a little bit about the root causes in terms of being in the clinical realm of the world that I have seen from my own practice in general, that really are what I'd say the foundation of injustice that happens within the mental health field. And we'll talk a little bit later about what the church can do, but we want to name what's happening in the field itself so that we as church people can kind of know what's happening in our community around us. And the root causes for based on what our presentation about justice is really these three things: stigma, discrimination, and oppression. And when we talk about stigma in this context, we're thinking about a stigma traditionally is a mark or of disgrace. It's a mark of shame associated with a particular quality of a person, in this case, a diagnosis or a mental illness. Discrimination, we're meaning really the unjust or prejudicial treatment of an individual or a community. So based on their mental illness, there's some prejudice that happens, and there's unjust treatment that happens to these people. And then over time, it actually develops into prolonged control or prolonged cruelty, which is oppression, prolonged unjust treatment for this individual or this community. And we see that really perpetuated over time through these various areas. And so there's four of them that I've seen. One is access. When we think about justice issues within the field, keeping in mind isms and microaggressions and privilege and the system itself, when we talk about access, we're asking questions like, who has access to services? Who do we tell that these services exist? Who even knows they're out there for us to get? How do we hear about it? Do people know about services because they're members of our church or our community, or members of something the space in which we talk about these services? Are these services only expressed in English, in one language? Is there a way that we understand these services if we cannot see or if we cannot hear? Are these services written in terms of languaging, in reading levels that are not an average comprehensibility for most people? Is there money involved? Do you have to pay for these services? Are there healthcare restrictions in the sense of does your insurance cover it, and how long does it cover it, and how do they understand what you need, and do you have support for that? One big issue I've seen for access issues is the time. When do these services take place? If they're during a work hour, then who gets to leave work to come to the service? If it's not at school, then what children have viable adults to drive them to these services? If it's at our churches, our schools, at our community centers, at our work where we're naturally going to be, then that might give us more access. But where is this, the timing of it, and where is it actually happening? Being in North Carolina, I've noticed there's a big discrepancy or disparities amongst clients who live in rural areas versus in the center city. And so in the rural areas, you'll find there's just less practitioners. There's less medical professionals out to reach the issues. The last thing we ask about access issues is citizenship or documentation. Do you have to have particular documentations like licensing and whatnot to get access to these things? And these particular issues of access become injustice over time based on who you are walking into, who you are outside of mental health issues walking into the situation. Another thing that we run into here is access to education in terms of just knowledge. What are we taught? How much are we aware of our issue? We find that how we interpret our own symptoms before we even get help really allows us to get help or not. You might describe your child as being violent and disobedient, and that my child might just be anxious at that time, but we don't know the language to be able to identify anxiety versus violence and disobedience. Knowledge issues around what types of services you might need to begin with. Somebody might tell you, you need psychiatric services, and that's typically someone who gives out medicine. That's someone who's trained to diagnose and give you medicine, where you may not know that that's not just talk therapy or marriage counseling. And so these things for clinicians, we might know because we're trained in it, but the average person may not know. So we want to make sure we do education in terms of access to even knowing where to start. The other education access issue we found is education around insurance and what insurance covers. I cannot express enough how tricky this can get based on your coverage. But some diagnoses aren't covered by certain insurances based on what we call medical illness. That there are some diagnoses that are considered medical in nature and others that are not considered medical, relational, marriage counseling, couples counseling. And so you may not know this. And so we want to think about who knows information to get their services met. The last, second to last, is mental health diagnosis patterns. I have seen this personally, but I've heard about it. You can Google it. You can read about disparity in terms of diagnosing. Who diagnoses with what? And if you know anything about diagnoses are really just a set of symptoms that we as medical professionals use to know how to treat you. So if you have a cough and a sneeze, we might say you have allergies. We might say you have an infection. We might say you have the flu. And depending on what we diagnose, we're going to treat you a certain way. In the mental health field, we do the same thing. If you're aggressive or you have anxiety or you can't sleep or you're not eating, we might name what you have. Where this gets tricky is that it's a subjective process, diagnosing, and all what my sister talked about in terms of all the levels of social interpretation and social experiences that the clinician brings into the office. We might base our diagnosis on how we interpret you. So we find in our field right now that minorities are typically diagnosed with certain diagnoses that are a little bit more harsh at times or might lead to more violent treatment. They're deemed more violent when it's just a perspective of the clinician. Historically, most assessment tools have been actually tested on predominantly white populations. And so cultural kind of coping skills and bound into being in a community that's been historically oppressed or has historic trauma aren't taken into consideration during diagnosing. So you'll see all the isms possibly come up for certain populations in diagnosing. The last one, and we're wrapping up here, is mental health treatment. Same thing, mental health treatment is a relational process. So it's a subjective experience between two people, and however their experience is in terms of their the person there in front of them that they're treating, but ahead of time can sometimes play in. This doesn't mean it always does. As therapists, we're trained to be culturally sensitive and understand layers, but this doesn't always happen. And so you find sometimes in treatment that it can be affected by the medical professional's perception. Some people who have convictions, depending on their convictions, sex offense, possession of marijuana, possible addictions, the treatment can be skewed. It could be based on the bias of the clinician. Also, certain populations like inmates, non-English speaking peoples, children, elderly populations, homeless populations typically can get different types of treatment just because of all the other things that we spoke about earlier, socioeconomic level, access issues. And so when we're thinking about how injustice plays in the mental health field, these are thoughts that we want to consider moving into what is happening for people, depending on who they are. And then as the church, how do we hold all this? We'll move quickly to our current advocacy issues. I won't go through all of these, and we can come back to some of them. The ones that are most important, I think, that going to kind of play in at this point is really around mental health coverage and people's insurance and what people can have. And so if you are currently doing advocacy in the mental health field, you might think about Medicaid expansion. The Affordable Care Act has allowed, at this point, some states to be able to extend Medicaid services up to people with about $60,000 a year, where before it was about $40,000 a year. So that opens up Medicaid for more people. Medicaid doesn't just do private insurance, but it also really allows states to do community programming. So case services, case management services, community mental health facilities, all kind of child welfare services comes from that funding. And we know that Medicaid is literally the single most, the largest mental health funding source in our country right now. So thinking about advocacy around those issues. Quickly, mental health care equity. So again, we talked about disparities. Some people of color will be treated a certain way based on other pre-existing biases of the professionals. It could be also people in certain communities, elderly populations, like we talked about, homeless populations, and how these people are getting treated. That could be an area you want to jump into. The last one I'll talk about, and we can come back to some of these, is mental health coverage parity. So right now in our insurance system across federally and statewide, mental health issues are not considered equal to medical issues. And those of us in the mental health field want to make them the same so that our insurance will cover them in full coverage like it does for our other issues. So we'll move on now to the church.